Yeah, and today we are very happy. I will be moderating the debate today, and we are very happy to present you this discussion organized by the PHM Equitable Health Systems and Food Sovereignty and Nutrition thematic groups, together with the Public Health Research Network India. The People's Health Movement is a social movement and global network bringing together grassroots health activists, civil society organizations, and academic institutions in the struggle for health for all. We currently have presence in around 70 countries, especially in the global south. The Public Health Research Network in India is a network of individuals and organizations that believe in strengthening technical and management capacities to achieve health for all. So today we are going to have 6 speakers in our program. First, Mr. Raman from the Public Health Research Network will give us a small introduction. Then Fran, Baum from the University of Adelaide and from the PHM will give us an overview of the Commercial Determinants of Health concept and framework. And after that, we're going to have some cases from Argentina, Brazil, and Kenya. And in the end, Angela Carriedo will make a final comment about the challenge for activism related to the commercial determinants of health. So thank you very much for being here today. We have interpretations in Spanish and French. So please, you can assign the language the best suits to you here in the Zoom interpretation menu under the screen. So without further delay, I invite Mr. Raman to make the introduction of this webinar. Mr. Raman is the national convener and founder of the Public Health Research Network in India, and an expert with more than 3 decades in the development sector. So welcome, Mr. Raman, please.
Thank you, Leo. I think my camera is not enabled, so I'm not able to show my face, but that is all right. Welcome everybody who joined this discussion, and thanks Leo and the People's Health Movement people who's organized this, and the Public Health Resource Network in India is happy to co-organize this webinar together with the PHM. And Public Health Resource Network is also part of the India chapter of the People's Health Movement, which is the Jan Swasthya Abhiyan. And in that capacity, I'm also the co-convener of the Jan Swasthya Abhiyan in India. So the PHRN is the secretariat of the Jan Swasthya Abhiyan currently in India as well, which is the so this topic, commercial determinants of health, is a very important topic as far as the PHRN is concerned, and also the People's Health Movement is concerned, because when we are talking about health for all, it is important that we are able to realize various impediments that is causing challenges for reaching health for all. In that sense, we had discussions about social determinants of health for a long time, and now social determinants are part of the broader discussion. However, the commercial determinants of health was, it was there already, and it has been discussed by several people in several ways. But to give it a very clear nomenclature and shape, and then looking deeply inside the issue, and to understand what are the kind of commercial kind of determinants of health, how are they kind of affecting the health of people, and what kind of issues are to be attended by various levels of governments, from local governments to provincial governments to national governments to international agencies. So there is a lot of things that we need to understand. And in a profit-driven world, in a market economy world, and in a neoliberal economy, that is broadly, kind of guiding the economic policies of the global situation, including that of the health situation. It is quite important that the market forces, how are they contributing to both sides of health, is to be recognized. There are some positive, factors, and some of the commercial actors, as the Lancet, the special issue that has come out about the commercial determinants of health has pointed out. There are some good things that is happening because of the commercial influence, but there are several issues that need to be identified, and several, things that we need to identify and address for improving, because these are affecting adversely people's health across various settings. So this is where the discussion around commercial determinants of health, Lancet, special issue, something that Fran is going to present here. That is one thing which is a good beginning, but we need to go further, go deeply about understanding this issue, classifying the problems, and then driving solutions, including various types of solutions, what the governments can do, what the private and commercial entities themselves have to do, what the community has to do. So I hope that this discussion, like the social determinants of the health discussion, happened some decades back, and now it is a prominent discourse across the public health community. I hope that this particular discussion will also, what we are, kind of starting today, although, this discussion across various authors and various experts, this is happening for some time now, and they have, reached some framework and some understanding, and some future kind of pointers has been derived. So I'm hopeful that this particular discussion that we are starting will make it a people's discourse across the needy settings, wherever the commercial determinants are adversely affecting the health of people, and we will have clearly, we will be able to clearly identify the problems and suggest solutions to governments and other, kind of agencies which are supposed to address these issues. And with that hope, I'm thankful to all people who are joining this panel discussion, the presenters here, the panelists here, and also the specific case study that are going to be presented today, and also the participants across the world who are going to listen to this webinar. On behalf of the Public Health Resource Network in India and the People's Health Movement Global, warm welcome to everyone around here. And we hope that, as I told earlier, this will make an important contribution to identifying the problems, and starting a very important discourse among various global actors, national actors, and local actors. Thank you so much. Back to you, Leo.
Thank you very much, Mr. Raman. So now, without more further delay, I would like to invite Fran Baum from the University of Adelaide, Australia, and also a prominent member of the People's Health Movement, to give us a more conceptual introduction on the commercial determinants of health. So, Fran, feel free to start. Thank you very much.
Yeah, thank you. I think my video is still is still off, but if someone could turn it on, that would be great. So
yeah, I think now you can. Fran, sorry.
Yeah, I think I have to stop sharing to do it by the looks of it. Just a minute. Sorry, I'm just going to stop sharing to put my video on. No, it still won't let me. Never mind. Oh, there we are. There. Hello, everybody. That's good. Good. There we go. Share. And yeah. So I'm going to talk about the Lancet series, but also look at perhaps some of the issues and the ways in which it wouldn't be entirely compatible with the People's Health Movement view. Can you see the whole screen view now, Leo? It's good on the first slide. Great. I think the first thing to remember is that although we're saying commercial determinants are new, they actually aren't new. I think there's been a long tradition of looking at commercial determinants of health. And if you think back to Engels in the Industrial Revolution of the 19th century, he was really looking at both social and commercial determinants of health, looking at the impact that poor living conditions, poor working conditions have on people. So that's the first thing I think we really need to remember in this debate, that there's been a focus on commercial determinants for quite some time. The other background issue is that, of course, we've got a whole range of crises in the world, and that the commercial determinants are both reflecting these and both fueling them. Just going round this kind of polycrisis, we've obviously got an ecological and climate crisis, and a lot of that is reflecting excessive extraction, the destruction of country, pandemics, unsustainable food, and so on. A financial and cost of living crisis, where there's heavy austerity, wages are falling behind, but profits are increasing. There's a social crisis, partly fueled by the kind of consumerism that goes along with the sort of commercialization of economies, with societies people becoming isolated, declines of solidarity, and all that sort of feeding into political leadership that's been pro-profit, neoliberal, privatization of many public assets, populist leaders increasingly, and declining trust in many political systems. And then finally, war, conflict and occupation, which is increasing under climate pressures, but also there are many commercial factors that are driving the wars. And of course, at the middle of all that, we have an unfair global economic and political system that's really driving this kind of polycrises that we're facing. So the Lancet series, this series was actually sponsored by the Lancet, but also by a health promotion group in Victoria in Australia called Vic Health. And they're a health promotion group that actually do pay considerable attention to the social and commercial determinants of health. And the series consisted of 3 papers. I'm going to talk most about the first paper because that's the one that defined and commercialized, and I've only got 10 minutes or so. I'll talk a bit more about that paper. The second paper was about looking beyond unhealthy commodities and trying to look at the sorts of questions you have to ask about different commercial enterprises to see what the extent of their impact on health might be. And the final paper was about the sort of future directions of the commercial determinants of health. Now, in that first paper, looking at the sort of model of the commercial determinants, how they worked, you can see that what we drew on here was the famous Whitehead and Dahlgren rainbow of social determinants of health. And here we work out from ill health and inequalities here at the centre to looking at the sort of final routes that come through environments, public policies that are increasingly influenced by the commercial sector, regulatory approaches and upstream policies which really enable and embed the commercial sector influence, and limit options for public interest policy making. And I'm going to say more about that. And then, of course, this political and economic system that increases the power of the commercial sector and sees it involved in all aspects of society. And in this in the square on the sort of upper left hand is the sort of the growth strategies, the business models that companies use, and their political practices, scientific practices, marketing, financial, labour, their reputation management practices, how they manage their own reputations, and of course their impact through their supply chains and waste practices. So it leads to this set of norms which are largely shaped in the interests of the commercial elite. There's the massive impact of externalities, which are passed on to the state and to society in general. And some of those are health, some of those are environmental externalities. And then, of course, the whole issue of power, the massive growth in the power of the commercial sector in the last few decades. So that's the sort of scoping out. And of course, those impacts, as that rainbow expands, the impacts are more global rather than local. And of course, finally, the impacts are on individuals. So just to go through the sorts of impacts on health that we were really putting into that diagram. So in terms of their practices, here's a whole list of them. I think tax evasion and corporate subsidies make a huge difference to the funds that are available for a whole range of public goods, including education, health and social services. And we know that there's a whole industry of tax evasion, and most corporations do receive considerable subsidies from governments around the world in one way or another, either by direct support or by favourable taxation regimes. Advertising, of course, encourages the consumption of unhealthy products. We see that, for instance, when tobacco laws became much stricter in many high-income countries, then the advertising switched to low and middle-income countries, including marketing to women, for instance, to increase the size of the market. Corporations are able to influence science through the funding they give to universities and academics, and that can be about producing favourable evidence, dissemination and the use of that evidence, but also suppressing evidence that is pointing to adverse health impacts. There's been a whole history of corporations denying the health impacts of their products, whether that's smoking, lung cancer, or breast cancer. And if those issues do come into the public domain, then there's a sort of a whole narrative that shifts the burden of responsibility to individual consumers. There's a huge industry which is just geared at lobbying governments to get corporate-friendly practices. And they can also, increasingly, corporations can influence governments and policies through consultancies, through the outsourcing of public sector functions to consultancy companies, and through the sort of multi-stakeholderism, where particularly in global health, corporations are able to exert a lot of influence on global health matters. There are numerous conflicts of interest. I don't have time to go into those, but there's so many. There is, people say, well, what about corporate social responsibility? But that's very often window dressing. And of course, corporations are mandated by law to maximize profit, not to be socially responsible. So they might be socially responsible if it's good for profit. And I've already mentioned the externalization of costs. I think one of the things we want to think about in analysing the impact of corporations is the whole issue of the state and the commercial determinants of health. And neoliberal policies have seen state bureaucracies downsized and restructured. Public services have been hollowed out, or in the case of low and middle income countries, haven't been built up. This has resulted in trust in governments has declined. Corporations are now often larger and more powerful than many states. Political parties in many countries depend on donations from large firms. You just have to look at gun law, for instance, in the US, but certainly in terms of many other unhealthy products, there are massive donations made to political parties. And economic considerations are usually dominant in most liberal democracies, which is very much to the detriment of health and equity. And privatisation has corporatised services that were previously public. So that's really clear. One of the things I want to talk to, and maybe in discussion we can come back to this, but in Australia, it's become very evident that the big consulting companies like Deloitte's, Boston Consulting, KPMG, and so on, are really undermining a strong public sector because so much outsourcing of functions has been to those kind of companies. And those companies don't typically promote equity or have the long-term view required to put equity in public policy. There are huge conflicts of interest. We've had a big scandal in Australia where PwC was doing a consultancy for our tax department and immediately passing on the privileged information it had from that consultancy to its private sector clients, telling them how they can avoid the new tax laws. That's just one example. this book by Mariana Mazzucato and Rosie Collington really calls this the big con and looks at how the consulting industry is weakening our business. And I increasingly think this is a really important mechanism of neoliberalism to undermine democracy and democratic states. So they're very undemocratic practice. They don't disclose who they work for, while they say, oh, we put in we try and avoid conflicts of interest. It's not clear how that happens. And in Australia now, they're called shadow public services, and our National Senate is having an inquiry into the influence of those consulting companies, and the submissions to it are very interesting, and it would be good to think about how many other countries that's a big issue. I can't say much about this, but I do think we need a political economy frame to critique corporate determinants of health. And it's really pleasing to say that there's growing attention to Marxist political economy within public health. And I think there'll be more and more, because it really does give the kind of critique of the sort of society we've got, of the impact of privatization, colonialism, global health, neo-imperialism, racism, exclusionism, and alienation from so many of the processes of corporations. And Marxism does present a set of values which challenge commercial determinants of health. And of course, from a people's health movement point of view, it calls for people to join the struggle against the kind of exploitations. So I think as an analytical tool, but also as a kind of political organizing tool, it's a great frame to look at. Just in closing, the final paper of the Lancet series looks at some alternatives. I would think that the alternatives we need to look at are cooperatives. There are actually evidence that people who work in cooperatives, it's good for their health, but it's also good for the people who are using cooperatives, because they're actually a democratic form of organization. The reversion of privatization, so taking back a whole lot of services back into public ownership, building strong and pro-social public sectors. And I think that needs a lot of thinking through. What does that mean? How can you ensure we don't get bureaucracies that actually work against people, but bureaucracies that are participatory and which involve people in decision making? And I know in Brazil there have been some good experiments with those sorts of things, and in other countries. There needs to be a massive restoration of workers' rights, which have been greatly undermined because often of pressure from business groups and corporations, and also a strong focus of government processes that eliminate conflicts of interest and at least opens them to daylight so we know what they are. So that's a very rapid rush through my sort of take on the importance of the Lancet series. I think it's important. I think the Lancet series involved a lot of authors, so it wouldn't necessarily reflect all our points of view, but I think it's really important that it was there in a medical journal and recognised as a really important factor affecting all our health at this point in the 21st century. So I'll stop there and look forward to a discussion and hearing the case studies. Thanks.
Thank you very much for this wonderful introduction to the commercial determinants of health. So, following the order, I would like to ask Arthur Monte Cardoso from Brazil to go first. Arthur is a professor in the Institute of Collective Health of the Federal University of Rio de Janeiro, and have been carrying some research related to privatization and financialization in the Brazilian health system. Please, Arthur, welcome.
Okay. Good morning, good afternoon, everyone. Let me just share the presentation here. Okay, can you see it? I think it's okay now. Okay, first of all, I would like to thank you, the People's Health Movement, for this invitation to discuss the case of Brazil. I'd like also to thank you a little bit, not yet. Just a minute. Well, okay, no problem. I'd like to thank you also my postgraduate student, Karina Correia, is helping me with my classroom now. And so I can be here this morning with you. I'm going to be direct. I'd like to discuss the Brazilian health system. and the presence of a great, large, powerful private sector with a universal health system that we have here in Brazil. The Federal Constitution of 1988 established that health is a right to all and duty of the state. And within the Federal Constitution, we have created the Sistema Único de Saúde, SUS, Unified Health System, or SUS, that is a free universal system with comprehensive care, decentralized management and competencies, and social participation. However, the Federal Constitution established also that healthcare is open to private initiative. It's established in the Constitution. And as a heritage from the military dictatorships in Brazil from 1964 to 85, health policies, in 1987, already 20% of the population had already a private health plan or insurance. And we had already a great provider health services sector. So we have this great private sector together with the public universal system. Okay, let's go next one. So Brazilian health system could be defined as a made up of complex network of complementary and competitive service providers and purchasers, forming a public-private mix that is financed mainly by private funds. So it's a little bit difficult to discuss because people that are covered by private health plans or insurance also can use the public system. And a major problem in structural issue is that from the total current health expenditure in Brazil that reaches into 2019 9.6% of the GDP, 56% is private expenditure and only 41% is public expenditure. So we have a universal health system, but we have the majority of the health expenditure made by private health plans or out-of-pocket expenditure. And the public system, SUS, buys from the private sector approximately 17% of government consumptions of health services in 2019. Okay, next one. It expresses the inequality and the privatization of on health expenditure. If you watch this inequality within the health functions, percent of total in Brazil. So only the general outpatient curative care, that is private health care in Brazil, is majorly public expenditure, 77%, and the patient transportation also, this is the mobile emergency care service. The other health functions are always privatized. The majority of the expenditure is private expenditure. It shows in the inpatient curative care, hospital services, dental outpatient curative care, all the diagnostic services, and so on. My research group, GPDES, has studied the big companies and the big business in the healthcare sector. We analyze it from the point of view that financialization is a new and systemic pattern of wealth, capitalist wealth and accumulation pattern. So the growing size of the health market is already very big, as I showed to you, led to the formation of national companies in health service, commerce, and industry in the last 20 years that covers all the countries, regions, and subsectors. The concentration and centralization of capital was possible by investment funds, foreign shareholders, initial public offering at the stock market in Brazil, and several operations of mergers and acquisitions. So we have today great examples of big companies. We have Amil, that is owned by United Health Group of USA, is one of the top health plans company. We have Bradesco Saúde, that's also owned by a bank, Bradesco Bank, one of the biggest ones in Brazil. We have one of the top 10 player in the health plans market, Apvida, that have merged with another one of the top 10 player in this market. We have a national enormous hospital company that's CDoH, that has merged with another health plan sector company, SulAmérica, and DASA, that comes from the diagnostic services, that has acquired a hospital company. And we have another example, that's RD, Raia Drogasil. It's a drugstore company that concentrates 15% of the retail pharmaceuticals market already. So it's a great market. From the model of commercial determinants of health, so I would like to show the importance of the financialization combined with this commercial entities and the economic and political power that emerged within the last 20 years. So we have big companies in healthcare with growing economic political power, multi-sectoral presence, and complex relation with the public system, SUS, and the state also. So it's combined with financialization, the manifestations of financialization in the Brazilian health system, the Brazilian economy, like the orientation for profit distribution, the corporate governance to shareholders, and even if they are owned by family groups or investment funds, they are the same financial logic of accumulation. And in this complex system, we have emerged hybrid entities in the public, private, and third sectors, just like in the second paper of the Commercial Determinants of Health, combining the participation of private sector, public sector, and third sectors. Very difficult to regulate, very difficult even to understand and to describe. I would say, for some examples, just to finish, my time is finishing. We have a medical cooperative, Unimed, from physicians, that became one of the largest network of health plans. We have SPDM, that it's the biggest company in management of SUS institutions as a social organization. We have a state-controlled company that reunites the Federal University Hospitals, EBSER, and we have also hospitals of centers of excellence, they're so-called, like Albert Einstein hospitals, Sírio-Libanês hospitals, where the presidents of the republic have surgeries, etc. And they have tax and social contributions exemption, and they also works in the management SUS institutions. Just to finish, I'd like to share this complex situation of the privatization of the Brazilian health system. The framework of commercial determinants of health are useful to describe and to go further in this discussion, but I'm like to agree with Fran Bauer that we must go further to develop a political economic frame to discuss those inequalities and the privatization from a critical point of view of capitalism that's manifested in health and healthcare sector, also make very complicated the access to healthcare in Brazil and the guaranteeing of the health right to all. So thank you very much, and good morning, good afternoon.
Thank you very much, Arthur, for showing to us how financialization is binding with the private sector in Brazil. Definitely an interesting case. Now I give the word to Laura Piaggio. Laura is a member of the nutritional program from the Buenos Aires Ministry of Health, the City of Buenos Aires Ministry of Health. And Laura has a large experience with child food and child food industry. So Laura, please, Miguel, can you please share the presentation for Laura? Just one second.
Buenos días.
Good morning.
Un momento, Laura.
Sí.
Okay, please go ahead.
Buenos días. Muchas gracias
Good
por la
morning, and
invitación.
thank you for your invitation.
por la oportunidad de
and for
compartir
the
este
opportunity to share
momento.
this moment with you.
Estoy hablando desde el celular porque tuve un
I'm
problema
speaking
con un
from
corte
my
de luz
cell
en
phone
mi casa.
because there was a power cut at home.
Voy a tratar de
I'm
sacar la
going to
interpretación,
try
que
and
estoy escuchando a la vez que, perdón.
remove interpretation because I'm listening to both channels at the same time.
Bueno, en esta oportunidad quería
Well,
compartir con ustedes
I wanted to share the
algunas
following with you.
informaciones
This
respecto
is
a
information regarding
las violaciones del Código Internacional de Comercialización de Sucedáneos
infringement
en Argentina.
of the International Trading Code of breast milk substitutes in Argentina.
Laura, I think Laura had some problem here. Yeah, we lost her. Let me check here quickly on WhatsApp. Sorry, just 1 second. We're trying to fix. I'm trying to get in touch with her. Okay, so Miguel, can you please stop the presentation? I was talking to Laura here. We'll give the word first to David. David, are you there? Could you present right now for us? Okay, David's here. So thank you very much, David. Just to introduce you very quickly, you can complement if you want. David Makori is from the People's Health Movement in Kenya. He's a doctor. So welcome, David. Please feel free to use your time as you wish.
Thank you very much, everyone. Good morning, good afternoon, and good evening to everyone. Mine is just to bring to you the health situation in Kenya and the challenges that our health system face, and also to bring to your attention what PHRN Kenya is doing to improve the life situation of Kenyan people. So I'll start by saying that Kenya, as a constitution that provides right to the highest attainable standard of health to every Kenyan, and places a fundamental duty on the state to take legislation, policy, and other measures, including the setting standards of right to health. And in recognizing this, it provides also a framework to ensure that a comprehensive right-based approach to the delivery of health services. So in Kenya, health is a devolved function, and this is following the adoption of the Kenyan Constitution. The devolution provides devolution of health services in Kenya aimed at bringing health services closer to the people and improve access to health care, and also address each county-specific health needs. So to realize this, Kenya has developed, has generated or has put in place laws, policies, practices, and procedures to make this a reality. And in recognition of this, Kenya has also came up with a Vision 2030 that was designed to transform Kenya into a global competitive and industrial country by providing its citizens with high quality life in a clean and secure environment by 2030. So the vision also identified economic and social political pillars to drive the country to realize its goal. And also in that, Kenya also has a national health insurance scheme, which is a national scheme aiming at the access to universal health care. So this drives the realization of universal health care. So now when we come to health system, Kenya has a wide range of health facilities that is operated by government or faith-based organizations or CBOs, international communities, and individuals. So in that, Kenya Health Systems defines 6 levels of hierarchy. And one of them is level 1, which is a community service. Level 2 is dispensaries. Level 3 is health center and maternity and nursing homes. Level 4 is sub-county hospitals and medium-sized private hospitals. Level 5 is country referral hospitals and large private hospitals. And level 6 are referral hospitals. And these referral hospitals are at the national or at county levels. And also it includes the private teaching referrals or private teaching hospitals. So when in achieving universal health care as one of the targets which member states sets when adopting the SDGs in 2018, Kenya is among the countries that ratified and committed to UHC at the United Nations General Assembly. And in 2018, universal coverage program was launched in Kenya as a piloting project in counties of Nyeri, Isiolo, Machakos, Kisumu. And these 4 counties were selected due to their high incidences of communicable diseases, non-communicable diseases, maternal and childbirth, as well as road accidents. So UHC in Kenya adopted a two-phase medium-term approach, of which first phase was expected to abolish all user fees at primary level and health centers, and also in extension to secondary, that is county referral hospitals. And second phase was to roll out the social health insurance scheme through NHIF, National Health Insurance Fund. So this contribute what could be mandatory for all Kenyans above 18, while the government will implement the scheme by providing the payment for the poor. So on that, we realized that in implementing this, Kenya rushed over the UHC, of which after piloting, our research says that Kenya didn't achieve its aim as per universal health coverage. And this they forgot about that for UHC to work, it requires a strong primary health care and as a foundation of health systems. So right now, Kenya is facing challenges in the people of Kenya are facing no challenges when going for health needs, because the primary health care, that is the foundation of health systems, was ignored at the time when they were piloting the universal health coverage. So as things are now, we are witnessing a dramatical shrinking of human resource for health in the public sector. This is affecting the delivery of services. And again, there is a reemergence of infectious diseases such as HIV, tuberculosis, pneumonia, diarrhea, malaria. Those are top or leading causes of mortality in Kenya, of which these diseases, if we had a strong primary health care, then these will have not been the top leading diseases in Kenya. So another challenge is that the government of Kenya, while implementing the UHC, they overlooked at a strong and well-functioning and sustainable health systems capable of efficiently delivery and managing healthcare services. And this is very vital when you want to improve status of the people. And this is ignored by the government. Another challenge we are facing is this poor sanitation and hygiene, inadequate water supply in health facilities and communities where people live, and also environmental factors and malnutrition. All this contributes to high prevalence of infectious diseases. And this situation is also compounded by disparities in knowledge and access to basic hygiene practices. So this one means that the commitment that many states made at the Alma Ata in 1978 is ignored. And our government is rushing over to speak or instead of serving the communities or people that need help most, they are serving the interest of WHO and other private sectors that commercialize health. And also,
just 1 second, can you please conclude in 1 minute, please? Because our time is almost finished. Please.
Okay, we are faced with what we call neoliberal policies. We see here in Kenya, our health is now in the market. Our government is adopting the discourse that does not belong to us. So we are copying or we are practicing health systems that are in the global north, forgetting about the health systems that do well in our global south. So slowly we are seeing the government removing medical services from hospitals to private sector. And now hospitals are being privatized through public-private partnerships. So this one means we are being tied up to and again, diseases are no longer calamities because we take too much on profit for profitable businesses, for investors. And we are also faced with the high strike of nurses and doctors due to lack of pay. We're also faced with the limited access to health care facilities in the rural areas, and also poor infrastructure and all that. And also government is making bills. Now we have many bills in parliament that one of them is primary health care bill. 4 of them are in digital health bill, facility improvement financial bill, and also they are creating funds, primary healthcare funds, social health insurance fund, and emergency chronic and critical illness funds. All these funds, we suspect that instead of benefiting the poor, they'll be benefiting the rich and corporates that will provide all this. And so in summary, we say that this is the time that we pull out our communities and health workers to bring the process and links that based on comprehensive primary health care. This is the time we put at the center the social policies, actions that address the social determinants of health. And also, this is the time we call our governments to honor their commitments. So for those few remarks, I say thank you.
Thank you very much, David, for your presentation. Now we move to Laura. Laura, are you there again?
Sí, acá estoy. Espero no tener de nuevo problemas. Sigo con el celular.
Yes, here I am. I'm still with my phone. I hope I don't have any trouble.
Can you show her presentation, please? Great. Please, Laura, go ahead.
Bueno, muchas gracias.
Thank you all.
Comentar antes, la idea es,
as I was telling you before, my idea is to focus on the infringement of the International Code of Breast Milk Substitute in Argentina. So, as an example, to talk about a commercial determinant in child health care. This paper was done in the framework of the
de la sociedad civil.
Sanar Foundation.
Y recientemente también el reporte en español. La siguiente, por favor.
Next slide, please. We all know
Leche humana
breastfeeding is the norm. Breast milk is the only food that belongs to our species and it's the only universal food. But however, breastfeeding isn't natural and it requires a learning process. Especially, it requires an environment that makes it easier. So what we can see and has been highly documented is that one of the factors that undermines breastfeeding the most is trading and marketing, unethical marketing of breast milk substitute. That is why in 1981, the World Health Assembly voted for an international trading code of breast milk substitutes, which is non-binding. So they don't have to incorporate it necessarily in their legislation. But in Argentina, it has been incorporated in some laws and resolutions. And so incorporation is fragmentary and dispersed. Breastfeeding in Argentina shows that with the latest data of the survey from 2019, we can see that less than half of babies are breastfed up to the 6th month exclusively, which means that at an early age, more than half of babies introduce ultra-processed foods such as commercial child formulas. This early introduction entails externalities because it implies serious health issues. It increases risks that are avoidable, such as child diarrhea, child acute respiratory illnesses, child obesity, and of course, it also has an impact on mother's health. We can see estimations of the tools, the cost of not breastfeeding tool. This is the name of the tool, and we can see there's a great number of breast cancer, ovarian cancer, and type 2 diabetes cases that might be avoidable with better breastfeeding rates. Apart from these externalities in health, we can also see great cost in the health system, in the economy of households, and environmental impact as well. Please, the next slide. Thank you. What we can see in Argentina is that the market of infant formula is an oligopoly that is highly concentrated. We have 3 companies that commercialize the different brands. They are all transnational companies, 2 from Europe and 1 from Argentina. Next slide, please. Upon observing the key practices of the commercial sector used to shape policies and norms, as described in the Lancet series, I would like to focus on marketing practices of infant formulas. Particularly, I'd like to look at labeling and digital marketing. In the mentioned article, we were able to see that 100% of labels in all the products considered to be breast milk substitutes in Argentina, which are products up to 2 years old, are not complying with the labeling norms on a national level. Next slide, please. The elements that are most infringed are nutritional statements and images and text that idealize the use of product. They make it seem ideal. They are not complying with the Argentinian norms. And when these companies are sued, they reply that these labels have been accepted by sanitary authorities, which is true. These authorities that register the products approve these labeling with these images. So we can see there's a deficit in auditing and in auditing and monitoring, and they then approve of non-compliance. So companies are safe from any kind of complaints, and consumers are defenseless. Another strategy used by the company that is highly documented in the scientific evidence is the diversification of products so that they can do cross promotion. So they market products that are outside of national regulations, and we can see that this line of products are based on the similar design where the logo is, and there are small differences in number. But in terms of marketing, in Argentina, since 2015, when they say that the code covers up to 24 months old, then what happens is that for milk for children that are 2 years old or more, there is a loophole. Companies say these are not breast milk substitute, but rather complementary food. In this interpretation, the auditing authority has allowed for marketing to continue, and so it's everywhere in the digital channels, despite several suing of these companies. So some authorities might want to hold them accountable, but there is a loophole. So in January of 2023, this year, the auditing authority established that indeed these products were breast milk substitutes, and they failed to approve marketing of these products. There are other products that are not part of Argentina legislation, which is modified milk aimed at 2-year-old children. So nowadays they use this segment to market their products. But by marketing this product in particular, they are marketing the whole of their products. So these products that you can see on the screen are not considered to be breast milk substitutes, but they end up advocating for that. So we can see that the state action is liable to respond to company pressure. They approve the labeling that is non-compliant with the current legislation. The marketing was allowed for 7 years because of the interpretation that was done of the norms. So there are norm loopholes everywhere. So facing this situation, many organizations of the civil society try to complain and by using the administrative channels that exist and try to hold these companies accountable. But on the other hand, a coalition of organizations of the civil society has been formed, and this is remarkable, and it's mentioned in the Lancet series as one of the pathways that we can go through. And so the network for the law of the code was formed. They have a project to work on this comprehensively by incorporating all the resolutions from the World Health Assembly. This project has recently entered both legislative national chambers in August and September, and currently we are working jointly with these organizations in this network for the code law to create some incidence actions that go hand in hand with the legislative treatment of this project. These were the comments I wanted to share, so thank you so much.
Thank you very much, Laura. So now we wanted to have a final comment, a critical comment from Angela Carriedo. Angela is a researcher in public health and nutrition and food policy. And Angela is also the policy secretary of the World Public Health Nutrition Association. Are you there, Angela? Welcome.
Yes, thank you. Thank you. Can you see me? Hi, everybody. Thank you for having me here today and to talk about some final comments. Thank you, everybody, for this webinar. It's really interesting. I just want to, as everybody pointed out, we know that one of the key ways in which industry interfere with the work of activists and academics and policymakers, as you know, is to delay, to weaken, to distort or deflect or make difficult for things to happen in terms of food and nutrition policies. So we are always questioning ourselves how us as activists or academics can support or counter these actions. And as everybody here has mentioned, there are several ways in which we either have done it or are doing it or are trying, although sometimes it's very disencouraging because we are exposing, right? So I don't know if I can share quickly my screen. I don't know if you can see my screen.
Yeah, it's good.
Yeah, I just need to put it in. Can you see the full slide, right?
Yeah.
Yes. So here are some, I just pull out some few things that some of us have already done or are familiar with, and I will just talk about some of the risks we find when we do this, right? So, for example, we are trying to understand better how corporate actions work or what they do, and obviously our previous panelists have done an excellent job in doing that. And what we normally do against that is obviously to do some exposés, case studies, doing a lot of scrutinization and taxonomize different types of actions and what are they doing, right? And it's very important. We have had some ways of doing it with freedom of information request and find more how things are happening, as Fran showed it, like what is happening in Australia with the shadow public services and so on. So doing these exposés helps us to gain more collaboration and coalitions of people who are interested in the same thing. Obviously, we want to improve the financial transparency of corporations and the investments, etc. And obviously, we need better mechanisms to minimize industry engagement in food policy and in public-private partnerships or multi-stakeholderism. So there are some countries that have, or some civil society groups that have developed conflict of interest tools. And we need to look at those positive deviance solutions and try to talk to them on how they did it, or how did they use these tools, for example, for meetings in the Senate or in different tables of discussion, so we can keep the industry away. Another way we have done it, or people have done it in the past, is obviously strengthening social movements. We have very strong social movements now, as this one, and we need to engage more in campaigns or to obviously counter the corporate power. As I said, exposing PPPs and multi-stakeholder partnerships and how they are being completely co-opted by industry and corporate interests. And another form is activist investors that go into the meetings to file resolutions to improve conscientization among investors. So what happens when we do all these things? And I think we all have been in that place. We are at risk all the time, and we do need to have better tools among our groups to protect ourselves. We obviously are keen to be intimidated and have personal attacks. We have seen this in several cases. This case that I just put in this slide is one that happened in Mexico, where a guy who is now working with Coca-Cola and was previously in the government has been constantly intimidating public health advocates in the country publicly. This is through a Twitter, but also some activists in Mexico, in Colombia, and other countries have been personally attacked and have their families at risk. There are people who need to go to the other countries because, especially in low and middle income countries, corporations have the power to intimidate activists. So we need to protect ourselves against that. Obviously, they discredit the work that we do and the sources, the evidence we use, and the networks with academics and things. So they are always discrediting what activists do or say about their actions. And they shift narratives and gain space in mainstream media. So obviously we need to find ways to protect ourselves. So I think building coalitions and exposing things outside our own country is important. It's important to find a way to communicate with each other if we are working with activists in different settings, or to find encrypted media platforms that allow us to have more private conversations and be very disciplined on how we communicate with each other, and obviously try to have some contacts in people who can help us expose these intimidations or personal attacks. So in conclusion, politics is fought with politics, right? So we need to be involved in campaigns that deal with the political economy of commercial actors. And it's very disencouraging when we feel that it's very difficult to fight back, but we need to be here. One example, sorry, I left the thing there, but we have a very, very important report by the UN rapporteur on the right to food. I'm sure you're all familiar with that, very recent, and how he's changing the narrative, and he's very strong in saying what we need to change our food system and to fight the corporate power on it. And so we're building a better narrative on that. The political agility is difficult in this hostile environment, but it's a path, and we're getting little by little to better means of accountability and transparency. So even if it's one step, is one step. And one of our job, especially, is to bring the people who don't have the space and bring them to where they can talk more about their own issues as a front runners, right, of corporate abuse. So we need to guide them, help guide them, people who we are in the middle trying to bring people who really need more space to expose what's happening to their own communities, etc. And as Claudia and I wrote on this commentary, we must not only be organizers, but permanent persuaders. And obviously it's not easy. So I encourage you to do that through organizations and so on. We will have our conference next year. I invite you all to participate and come. We will have a lot of people, activists, politicians, etc., who are really worried about the hunger crisis globally and about all the commercial determinants of health, etc. So please, let's keep us united and protect ourselves by building strong communities and safe spaces. So that's all for me. Thank you. We can continue the conversation, I guess. Thank you, Leonardo.
Very much, Angela, for those wonderful comments. I think they fit really well to what we discussed before. So I'm afraid we don't have much time for discussion because we already passed a little bit our time. Yeah, there were some questions here on the chat related especially to how to confront the commercial determinants of health, which Angela had just discussed a lot. I don't know if any of the panelists wanted to make any final remark, any comments. If so, I would ask you to go quickly, please. Otherwise, we can finish soon. Well, so I think that's it for today. Thank you everybody for being here. We are going to have the presentations on YouTube very soon in English, Spanish, and French. So whoever wants to share the discussion afterwards with your comrades and your partners, this will be available on YouTube. I'd really like to thank everybody that's had their time to be here today. The attendees, I'm so sorry that we didn't have more time for discussion. And I also like to thank a lot Laura, Arthur, David, Fran, Dr. Raman, and also Angela for this wonderful presentation we had here today. Thank you very much. Hope to see you soon. Yeah, I have the PowerPoint presentations from the speakers, so I can share with you later. I have the contact of everybody who had registered. We will share that later together with the YouTube links. So thank you everybody. Hope to see you soon. Bye.